Right patellofemoral syndrome. So in this condition, oftentimes you're going to find hypertonicity more often in the lateral aspect of the upper thigh and down in crossing the knee. So you can reference other videos to find out the fascia releases for the IT band, the tensor fascia lata, and biceps femoris, depending if that one has got some restrictions and tightness. For fascial release on vastus lateralis, I can get it from this point using our crossed hand spread, engaging the tissue, which is the fascia, the fat, the skin, holding for 90 seconds, waiting for the creep to occur. Can then move to my direct fascial techniques with a glide using my palmar surface, going incrementally, 5 seconds or longer, just gliding far enough to not put additional irritation to the hair on the leg. And I can do a skin roll by elevating that tissue in between my thumb and fingers, using my fingers to walk as my thumb pushes that tissue forward and up. If I find a point of restriction, I can stop, create a C-bow, and wait for creep to occur. I would continue to do this through the whole vastus lateralis. We want to mobilize our patella laterally, as it's often medially, the movement is medial, or the placement is medial in patellofemoral syndrome. So I'm just going to place my hands on either side of the patella and moving and mobilizing that patella laterally. A grade 3 sustained to increase the stretch, holding for 8 to 10 seconds, repeating that 2 to 3 times. Now, if you find that the patella has been displaced more laterally, then you want to mobilize it medially. So you're just going to place your hands around the patella, go to a grade 1 distraction, and then a grade 2, and a grade 3, with our intent to stretch, holding that for 8 to 10 seconds, and coming back to a grade 2, repeating this 8 to 10 seconds into a grade 3 sustained, and a third time. Done. So left knee, ACL, MCL, sprain, strain. Later on, as it starts to heal, we're going to have some scar tissue that's going to be on the medial collateral ligament. So we're going to apply cross-fiber friction in this area. We have had our client flex his knee to about 20 to 30 degrees of flexion to open up our joint a little bit more. We're going to follow our joint line and then move posteriorly until we get onto the medial collateral ligament. We're going to engage that tissue. So again, it's a slight stretch from neutral to a slight stretch for a ligament for cross-fiber friction. Going to apply our pressure, and we're going to move about 1 to 2 centimeters and about 1 to 2 movements per second. We can do this for up to 2 minutes, indicating to our client this is a very aggressive treatment and we want to work within their pain tolerance. They should have some decrease in the amount of pain shortly after you've started. If there's been no decrease in pain, after 2 minutes, you're going to stop the technique. Once there is a complete decrease in pain, you're going to stop and apply a stretch, gentle stretch to the area. So in this case, we're going to apply a valgus-orientated directional stretch, placing hands on either side, moving our knee into a medial stretch, stretching our medial collateral ligament. We're going to hold this stretch for 30 seconds and then we're going to apply ice. You can apply ice in two ways, taking a small cube and using a towel to help with any drips that are facilitated, applying the ice directly onto the area and moving it across the area slowly until the client indicates that the area is numb. The faster you move the ice cube, the colder the treatment will be for the client. The slower you move, the less cold. Our second option is to place a cold pack onto the area. Making sure that it's supported and secure, and we could continue with other treatments while we wait for this to cool. Done. Okay. So pes planus, this client is presenting with that on the right foot. So I want to actually reduce the high muscle resting tone or the myofascial restrictions that I would have found in gastrocnemius soleus or the posterior limb complex. So we can work with our indirect fascial release techniques, a crossed-hand spread, engaging the tissue. So that's the fascia, the fat pad, and the skin. Waiting for 90 seconds for creep to occur. And we can move from here into our direct fascial techniques, which are going to engage the fascia, the skin, the fat, and the musculature below it. Our glide is slow. Our pressure is moderate to deep, depending on the structure that you're working on. And again, working within your client's pain tolerance. In order for a full stretch or extensibility to occur in the muscle, we want to do our fascial techniques for anywhere from 3 to 5 minutes. We can do skin rolling, which is a more aggressive technique, keeping in mind if it's too uncomfortable for your client to go back to your indirect or direct techniques. If you find that you can't pick up the tissue, as is the case in this client, you can provide a SIBO by using the web space of one hand and the fingers of your other hand, applying a force counteractive to each hand until you feel a release or creep occurs. With the Achilles tendon, we can apply a GTO by finding our musculotendinous junction, doing a crossed thumb SBO, which is a Golgi tendon organ release, which will reflexively drop the tone in the muscle. We want to hold this for 30 seconds or until we feel a release. So with pes planus on the right side, tibialis anterior often will get hypertonic or fascial restrictions because it's always fighting the power of the gastrocnemius and soleus, especially if they're shortened in this position. So we can do a fascial release with a crossed-hand spread by engaging the tissue, moving our hands away from each other, and waiting for 90 seconds for creep to occur. We can use our direct fascial techniques, palm or surface of the hand, and work with a glide. Fascial release is done without oil, but in certain situations, if you find that you cannot glide at all, you can use 1 drop of oil just to provide a bit of lubricant to facilitate the glide. With tibialis anterior, I can isolate and use my elbow by cupping and webbing my thumb and finger. I can place my elbow into that web space and move from distal to proximal along the tibialis, anterior. With pes planus, we do not want to mobilize the medial longitudinal arch, but we can mobilize the lateral longitudinal arch, which is going to consist of the cuboid and the fourth and fifth metatarsals. With pes planus, they are often rotated laterally. So we're going to isolate the cuboid, thumb and finger from anterior and posterior aspects of the foot, and we're going to medially mobilize in a gliding motion the cuboid. We're going to hold for 8 to 10 seconds, coming back out to a grade 2 and back into a grade 3. Then we're going to move between the fourth and the fifth metatarsals, going to isolate the bone from the dorsal aspect and the plantar aspect, and we're going to immediately mobilize. Going into a grade 3 sustained, back to a grade 2, and then into a grade 3, repeating this 2 to 3 times. So for pes planus, we have decreased dorsiflexion, so we're going to increase by doing a posterior glide on the talocrural joint. So I'm going to isolate at the talus, and I'm going to use my more distal hand to mobilize with a posterior glide, a grade 1 distraction, and then a glide. Holding in a grade 3 sustained for 8 to 10 seconds, and then releasing to a grade 2, back to a grade 3 sustained for 8 to 10 seconds. Repeating this 2 to 3 times. With plantar fasciitis in a prone position, oftentimes you can apply a little bit more pressure using your body weight in order to facilitate that lengthening of the fascia. So if you cup at the dorsal aspect of the foot and then anchor your fist, you can do a fascial glide from the calcaneus to the transverse arch. You can apply some extension of the toes and continue mobilizing with your thumb. You can flex the knee and mobilize the fascia using a thumb spread. Or if that tissue is still so restrictive for you, you can mobilize and use your elbow, creating the glide. In plantar fasciitis, you're going to find a lot of the same impairments in the proximal and distal limb as you would have found in pes planus. So reference those videos in treating those restrictions or impairments that you're going to find. We're going to speak specifically today about the fascia on the plantar surface of the foot. If this is not in an acute stage and we don't have acute inflammation, we want to work to address the fascial restrictions that are occurring in this plantar surface of the foot. We want to work right from the transverse arch all the way to the calcaneal tuberosity in order to create extensibility in this limb or in this foot. So we're going to take the toes into some extension, and I'm going to use my fist from the metacarpophalangeal joints to the mid joints, and I'm going to do a fascial glide with extension at the same time. I'm going to move from the most superior aspect to the inferior. I can use my thumbs if they're double stacked and create the same glide, or I can move from the inferior aspect superiorly. I want to work right into the restrictions on the transverse arch by doing fascial spreads. I'm going to engage the tissue and do a thumb separation, waiting for creep to occur. I can do this technique throughout the plantar surface of the foot. Again, creating a bit more stretch to the tissue and doing a glide with my thumb. So we want to stretch this plantar aspect. So you're just going to isolate at the calcaneus. The stretch is not geared to the gastroc-soleus complex. It's geared to the fascia. And then you're going to take the toes into extension and hyperextension, supporting calcaneus, and holding the stretch for 30 seconds. In this case, probably longer to facilitate increasing extensibility.